Hello, all. Welcome to this episode of Conceptual Anesthesia. And today we'll be talking about an important topic which can be classified under trauma and critical care. And this is about spinal trauma. So, we talk a lot about head trauma. There's an entity called spinal trauma. And let us see when a patient of spinal trauma presents to us initially, how we manage them, how we should analyze or assess the patient in the pre emergency, in the emergency, and in the ICU initially. So, spinal trauma as an introduction, spine injury with or without neurological deficits must always be considered in patients with multiple injuries. So, we often hear about the term polytrauma. So, when such a patient comes to us, we should always think about whether the patient is having a spinal injury or is not having a spinal injury. And just to tell you how frequently this happens, approximately 5% of the patients with brain injury have an associated spinal injury, whereas 25% of patients who just present with spinal injury have at least a mild brain injury. So it is very commonly occurring thing. And usually, as you know, our spine is divided into various regions like cervical region, thoracic, thoracolumbar, and lumbosacral. So majority of the injuries, spinal injuries, occur in the cervical region. That is around 55%. So more than half of the spinal injuries occur in the spinal region, whereas 15% occur in the thoracic region, 15% at the thoracolumbar region, and 15% in the lumbosacral region. So in patients with potential spine injuries, so as I told you, a polytrauma patient comes, we should think whether he is having a spinal injury or not. So these are all patients who potentially can have a spine injuries. When you excessively manipulate or inadequately restrict the spinal motion, this can cause additional neurological damage and worsen the patient's outcome. So all the patients who come with polytrauma should be assessed for spinal injuries. The two most common causes are vehicular trauma and unintentional falls. They are the leading mechanisms of the spinal cord injury. And older adults are more susceptible to spinal injuries. This is due to the underlying arthritic and osteoporotic conditions of the spine. So, after this introduction, we'll be covering the anatomy, the physiology, how we assess in pre hospital scenarios, initial assessment, neurological assessment. I'll talk about a detail in incomplete spinal cord injuries and the 3-4 syndromes that are very commonly asked in the multiple choice questions also, and the ICU management. So the spinal cord extends from the brain to the lower back through a canal in the center of the vertebrae. And like the brain, the spinal cord has three layers of tissues for protection, and CSF, which is a cerebrospinal fluid, surrounds it to act as a cushion against shock or injury. It sends and receives information between the brain and the rest of the body. So that is the important function that the spinal cord does. It is an extension of the brain, and through this the brain sends information and receives the information from the rest of the body. So as I told you, we can divide the spinal cord into cervical, thoracic, lumbar, and sacral. So cervical spinal nerves from C1 to C7 in the neck area control the back of the head, the neck and the shoulders, the arms and the hands, and the diaphragm. So when you assess the motor and the sensory functions, just remember the cervical spinal cord controls the back of the head, the neck and the shoulders, the arms and the hands, and the diaphragm. The thoracic spinal nerves, known from T1 to T12, in the upper mid back control signals to the chest muscles, some muscles of the back, and many organ systems. The lumbar spinal nerves, L1 to L5, in the lower mid back control signals to the lower part of the abdomen and back. So, thoracic is in the chest and organ systems, whereas lumbar is the most lower parts of the abdomen and the back, the buttocks, some parts of the external genital organs, and the parts of the legs. And then we have the sacral spinal nerves, S1 to S5 in the lower back. They control signals to the thighs and the lower part of the legs, the feet, the most of the external genital organs, and the area around our anus. So as we can see the same in the diagrammatic representation also. Now vertebral bodies are separated by the intervertebral disc that are held together anteriorly and posteriorly by the anterior and posterior longitudinal ligaments respectively. So between the two vertebrae, there is the intervertebral disc, and we have anterior and posterior longitudinal ligaments. Posterolaterally, two pedicles are there, which form the pillars on which the roof of the vertebral canal rests. And the facet joints, interspinous ligaments, and paraspinal muscles all contribute to the spine stability. So, at least this much basic we all should know. Now, when we talk about physiology, we should know that the spinal tracts, which take information to and fro from the brain to the rest of the parts of the body, can be ascending tracts and descending tracts. So, on the left hand side, we have the ascending tracts, which is the dorsal white columns, namely the fasciculus gracilis and the fasciculus cuneatus. Then the dorsal and ventral spinocerebellar tracts and the lateral and ventral spinothalamic tracts. Whereas the descending tracts are the corticospinal tracts, the rubrospinal tract, and the retrospinal tracts. So, at least we should know about these three tracts. The corticospinal tracts, the location in the spinal cord is in the anterior and the lateral segments of the cord. The function is to control the motor power of the same side of the body. And the method of testing is by voluntary muscle contractions or involuntary response to painful stimuli. So when there is an involuntary response, we move to painful stimuli. Then spinothalamic tract, it is in the anterolateral aspect of the cord. It transmits pain and temperature. So spinothalamic is pain and temperature, and we check it by the pinprick method. The dorsal columns is in the posterior-medial aspect of the cord. It carries posterior sense, position sense, that is proprioception, vibration, and some light touch sensation. So, by position sense in the toes and the fingers or vibration sense using a tuning fork, you can assess the dorsal column. So, we have to assess at least these three tracts. The spinothalamic tract and the dorsal column are usually sensory ones. The corticospinal one is a motor one. Now, we talk about sensory examination. One thing we should know is what is a dermatome. Dermatome is a skin or area of the skin innervated by the sensory axons within a particular segmental nerve root. So I talked about C5, C6, C7, C8 and so on, T1 to T12, L1 to L5, S1 to S5. So they are all innervate different areas of the skin, and for the specific nerve, the specific area that is innervated is called the dermatome. And when we talk about injury, we should know the sensory level. So commonly terminology is called the sensory level. The sensory level of injury is the lowest dermatome with normal sensory function, and obviously it can differ from the two sides of the body. So right side of the body and left side body can have a lower dermatome or a higher dermatome respectively to each other, in which the sensory level is intact, which has a normal sensory function. But you have to pick the lowest one out of the right or left. Commonly remembered the spinal nerve segments, which or even come in the multiple choice questions. The C5 is the area over the deltoid, C6 is the thumb, C7 is the middle finger, C8 is the little finger, T4 is the area around the nipple, T8 is the xiphisternum, T10 is the umbilicus, T12 is the symphysis pubis, L4 is the medial aspect of the calf, L5 is the web space between the first and the second toes. S1 is the lateral border of the foot, S3 is the ischial tuberosity area, and S4 and S5 is the perianal region. Then we talk about motor examination. So different nerve pathways relate to a specific muscle group. So when we talk about the muscle, we talk about the muscle groups. It is different in the upper limbs and the lower limbs. If you can see the image on the right side, and I'll be telling in a bit of detail later on. The C5 is the elbow flexor of the biceps. C6 is the wrist extensors. C7 is the elbow extensors of the triceps. C8 is the finger flexors. T1 is the finger abductors. So try and remember from C5 to T1. And then we move to L2 to L5 and S1. L2 is hip flexors. L3 is knee extensors. L4 is ankle dorsiflexion. L5 is long toe extensors, and S1 is ankle plantar flexors. So if you can paste a small pic in your room and you read about the dermatomes and the flexors and the extensors, probably in a week or 10 days, you'll be remembering them by heart. Now, how do you check them? We use a scale from 0, which is no contraction of the muscles, to 5, which is the normal strength, as a part of the international standards for neurological classification of spinal cord injury assessment. So this is international classification which is commonly used in most trauma centers.